Well, good afternoon, everyone. Hey, it's a pleasure to be here to reunite with friends and colleagues from both the community and around the state. Met a lot of good people from St. Louis and a couple of people from Columbia. An old and good friend of mine, Miss Debbie Chase, St. Louis, who's currently a consultant and policy writer, very bright woman that's worked with me in Minneapolis. Pleasure to see her a little while. I thought I would spend 5 or 6 or 7 minutes or so in a very brief introduction, take advantage of this audience to give a dual message. One, about the total state of affairs in our country relative to health care. It's just not equity for disenfranchised patient populations, but it's equity for everyone, as our system of care is not living up to its billing. And I thought I would use as a background some of the principles of the American Hospital Association, as this association of some 600 to 6,500 hospitals across the country are trying to shape and formulate a policy that our country can go forward with and improve the state of affairs over the next 4 or 5 years. It's about a system of poor performance, as I said, poor performance for everyone, and it covers the entire spectrum of our care delivery system, much of which is represented in this room today. It's about values and principles that I'm hopeful each and every one of you can agree with, adhere to, and hopefully help implement. And there are 5 principles. Very quickly, coordinated care. That's hard to argue with. We need to have a system of health care in our country where the care is coordinated, where the physician and the patient and the clinical information is at the right place at the right time, and hopefully on time. And where there is a navigator that helps constituents in our system manage the system. And all of you know it's necessary. If you work in large tertiary academic medical centers, all you have to do is walk down the halls a couple of times and get lost to realize that you need a navigator and someone to help you through the system with reimbursement issues, etc. Well, this system perhaps needs to think about paying for that, because many institutions across the country do that now, but it's without reimbursement, and it does yield benefit, and we need to think about that. The other very critical, important coordinating element that I'll offer to you is what our country needs to do about end-of-life situations. And not just the tragic ones that get on the news every year or so, but everyday end-of-life decisions that oftentimes are not made, and tremendous cost is associated with that without much gain. And we need to look at that as a country. The second point is access to information. Has to do with electronic health records. Many of you are somewhat aware of that, perhaps engaged with it, implementation of it. We have a major vendor here in our neighborhood, Cerner, that is involved with major implementations all across the country. A very, very expensive proposition. But we can't get to this utopia until we have electronic health information that's portable, that's available, and for that to happen, we need to have a unique identifier for each and every one of us so that information can follow us. So we have to get beyond HIPAA concerns and constraints, etc. If we're going to do this and do it right, we need a single identifier for everyone so that the clinical information can follow you. I might also add, we also need a funding stream to help implement these very sophisticated, very expensive systems. And I'll get back to that in a little bit. The other thing is, I talked to several of you in the public health arena, young lady at my table in Healthy Starts. How about wellness? How about a focus on wellness? How about sponsoring wellness? How about systems and insurance companies paying for wellness so that we don't have the heavy-ended expense and cost on the back end? How about reinstituting physical education classes? How about good nutrition? How about no smoking? How about everybody getting a good night's sleep? What are we going to do about obesity? Wellness needs to be very prominent and very important in the total scheme of things as we go forward. Lifestyle, big deal. We're suffering in this country as a result of poor lifestyle. Much of the focus on this new system has tended to dwell on access by virtue of millions of people, 47 million at last count, across this country that don't have health insurance. And we need to fix that. Richest country in the world. And we haven't done a thing about it over the last 10 to 20 years. At the rate we are going, that $47 million figure will be 75 million in 10 years. We need to fix that. We have 700,000 uninsured people in the state of Missouri. We need to fix that. It puts a significant burden on everyone, including our safety net providers across the country and in the state and in the city. Truman Medical Centers alone, as one single institution, provided $80 million of uncompensated care at cost, not price, at the wholesale rate last year. That's a lot of money. We need to fix that. And the last principle and value that I hope each and every one of you will appreciate is the value proposition. And that has to do with our services costing too much more than the other 18 or 19 industrialized countries across the world, and the outcome measurement not being as good. It's a double whammy. We pay more and we don't get the result or the outcome. It's a principle that we need to look at and fix. Let me put a little meat on the bone on that last principle. The Commonwealth Fund, about 7 or 8 months ago, put out a report that compared the United States on average against the best benchmarks in the world. And how did our results, our outcomes measures, compare against that? Well, let me tell you, not very good. When they looked at preventable mortality, these are people who are under 75 years of age and with the right access, the right treatment modalities, and the right care management, they would not have passed away. Our mortality per 100,000 in this country is 115, which is 43% higher than the best benchmarks around the world. Infant mortality, that should be near and dear to many of you in the audience. Per 1,000 lives, we lose 7 babies. The best benchmark in the world is 2.7 industrialized countries. We're more than twice the rate of the best countries in the world. Primary care access. We have 52% of eligible people accessing primary care, as opposed to better countries in the world having 80-some%. Big difference. Percent of doctors using electronic medical records. 17% in our country, 100% in other countries around the world. We must do better. We rank far behind France and Japan and Spain in terms of overall rankings and ratings in our outcomes measurement around the world. In fact, many times we rank 15th, 16th out of 19 industrialized countries. We must do better, and the utopia is that ultimately we have no preventable deaths, no avoidable deaths as a result of error, that we have only one time to ask people for their clinical information, so that each and every time you go to the doctor, whether it's your own physician's office, a hospital down the street, or a hospital across the country, they should not have to ask you for your demographic information. You don't do that every time you go to an ATM machine. If you do, somebody's taking your money. So 100% of all of our care should be evidence-based. That's the goal. And this country should be first in the world, among other countries, for clinical outcomes. Last but not least, and what is very germane to this audience, is that there should be zero differences in care due to racial, ethnic, or gender differences. And that's a big statement. Inequity and disparity in health care is a costly proposition, both in terms of financing and personal pain. When you look at congestive heart failure, and diabetes and other chronic illnesses in this country, which represent about 80% of our cost, which is about 16% of our gross domestic product. That's a big number in this country. Well, the rate for congestive heart failure among African American blacks in this country is 50% higher than Caucasians. That's not good. Diabetes death rate for blacks, 49 out of 100,000 population, as opposed to 23 for the majority population. That's a huge discrepancy. Hispanics, Latinos, American Indian death rates as a result of diabetes, sometimes in some patient populations, as high as 172 deaths per 100,000. That's more than 4 times the rate of white America. It's shameful, and we should do better. I'll leave you with a couple of points of thought that perhaps you can digest and hopefully reflect in your dialogue later today. And that is how we got here with many of these disparities and our system of care, and how it relates to history, culture, and public policy. And I just jotted a couple of things down yesterday over the years in my short lifetime of things that this nation has engaged in an effort to help the delivery system and access to care for all the citizens of the United States of America. Sometimes it's helped, and sometimes it hasn't. Medicaid managed care demos in the 1980s, big deal. Problem is, more times than not, it was more about managing costs than managing care. And a lot of people were disenfranchised as a result of it, discombobulated, changed around, moved around unnecessarily under the guise of a better care system, but indeed, more times than not, it was to save money. The 1970s brought on major public policy, the war on poverty, Lyndon Johnson as president, late 60s, early 70s, the neighborhood health center movement, OEO, 3-funded health centers, many of them are still around, Swope Parkway, Rogers Clinic in this community. Used to be Yateman in St. Louis, I don't know what it is today, but they really did provide access to a lot of disenfranchised minority recipients who were somewhat distrustful of other healthcare delivery systems, and there was good reason for that distrust. I'll get back to that. 1960s Medicaid, Medicare gave access to millions of citizens that were either aged, disabled, or over the age of 65, and has been a very successful program in terms of access. Now, we have begun through various policies over the years to start chipping away at that wonderful program because the cost is just running too high. But I'd also offer that at the same time our government was engaging and implementing those policies and those programs, it was also engaging in the Tuskegee experiment and other similar programs, quite frankly. That's a sad commentary on what has gone on in our country as a part of public policy from my point of view. And last but not least, in large part because of Medicaid and Medicare, many of the historical Black American hospitals have closed down because patients now have access to larger majority hospitals, and there is debate as to whether or not that's good or bad because of the cultural identification that many of those institutions provided and presented to that constituency. The Hill-Burton Act in the late 40s and early 50s, tremendous program, offered capital to hospitals all across the country, which resulted in over 500,000 beds being built in this country in the 50s and 60s. It also obligated those institutions to avail themselves to people who could not afford the care. It was a great program. That program has run out. Maybe we need to reinstitute it, or perhaps a Hill-Burton type program to help capitalize this technology that we need. Be a great policy, great policy. Well, it brings me all the way down to the 1860s. I've gone from 1950 to 1860s. And what happened in 1860 or 1863? The Bureau of Freed Men happened, which created dollars for a system to accommodate freed slaves. Grossly underfunded. These facilities were grossly understaffed. These facilities did not have the technology or intellectual capital necessary to run a sophisticated healthcare delivery system, even in the early 1900s. But it's the system that many of the clientele that all of us cater to and see today came from, or their parents, or their grandparents. And I bring that to your attention because I believe before we can fix many of the inequities that face us, we've got to understand where the people come from. And there's similar circumstances with legal and illegal aliens today, Latino and Hispanic patient populations, immigrants from different countries. I learned long ago that it's important to have language skills and interpreter skills so that you can interface and relate to all of these patient populations. But it's probably far more critical to understand the culture and where those patient populations are coming from. And by virtue of many of the public policy and habits and traits and discriminatory policies, many of those constituents don't trust the system. And we need to understand that and work with it and fix it. So I will leave you here today with one point before we criticize or stereotype. We need to understand the come from, where people are today and how they got there, and hopefully identify the right cultural mix, including staff and personnel, to interface and relate with the constituency that you're serving. My last point is simply this. Over these years, there have been numerous debates about health care being a privilege or a right. And I would submit that it's both, and it should be. And we need to throw in personal responsibility. Healthcare is a personal responsibility and a right, and it's a privilege if you can satisfy the first two. With that, I welcome you again to the community. Hope you have a good visit here, both in your conference and in the city. There are a lot of wonderful things to do, and I hope to see you all soon. Thank you.